For Your Health by Dr. Femi O. Today we're talking about cardiac problems in children. We know that children will not communicate with us until a certain age, and sometimes this can be challenging. To find out what's wrong with our kids might be, if we're not skilled enough, we might miss certain things that are important. In order for us to learn more about these conditions, we have with us here today Professor Animasahun, who will be taking us through some important, things that we need to know as parents and as adults when it comes to children, and to know the telltale signs of cardiac or heart problem. You're welcome to the show, Professor Animasahun.
Thank you so much. Thanks for inviting me also. Hello, viewers. Good morning.
Thank you so much. So, can you tell our viewers about you?
Okay. I'm Professor Animasahun. I work majorly with children, especially children that has heart problem. I've been doing that for about 22 years now. I'm a public servant. I'm accessible to many of these. I help, from time to time. I have various degrees, which may not be too important for this forum, both national and at the international level. I am trained at the national level, and I also have the international level. I'm quite experienced in this. I have quite a number of children with this under my care currently.
Thank you so much. So, heart problem in children. Can you tell us about this?
All right, heart problem in children. Thank you for inviting me once again, and thank you for bringing up a topic like this. Many people will have thought that why would children have heart problem? They're too young, they are innocent. You may be right to a certain extent, but I want us to know that in as much as we have heart problems in adults, we have also in children, and there are different types. The way we classify them, there is the type that the children are born with. That is what we call congenital heart disease. There's another type that it comes their way after birth. We call that acquired heart diseases. There are different categories. But I want you to know that it is as common all over the world. The incidence of congenital heart disease is the same, although that of acquired heart diseases differ. For congenital heart disease, it's as common as every 4 to 10 babies that are born per 1,000 births comes up with congenital heart disease. In other words, heart problem that they are born with. Unfortunately, even though they are born with this heart problem, the heart problem happens most of the time even before the mother is aware that she's pregnant. In other words, in the first 1 to 2 months after conception, which you will agree with me at that time, many women will still be like, oh, are they pregnant? Are they not pregnant? But unfortunately, the havoc most of the time have been done before then, and the baby is born with it. There are many things that could help finding out these ailments well ahead of time, because in our practice currently, the major thing is that because of the level of awareness is very poor, so oftentimes parents don't even know that this infant or these children, they have this problem, and so they come in late. In other words, this is, for example, congenital heart disease. This is a problem we said the child is born with. In some studies that we have done, which are accessible online, you just Google my name and find out incidence of congenital heart disease in Nigeria. We have made many publications on that. In fact, there's one that we talk about, time to diagnosis. We find out that for many of these children that are even born with this heart problem, we don't get to see them until they are close to around 2 years of age, wow, which is rather late, which in developed world, most of the time, the diagnosis will have even been made before the baby is born, such that as the baby is born, they are ready to tackle it. But we're not yet there. Maybe because most of the time, parents don't even know what to watch out for, which is one of the reasons why this program is coming up, so that we can educate the public and encourage, with increasing awareness, encourage parents to bring these children earlier. Because when they come in earlier, it is more likely that we're able to salvage them on time and even improve, the quality of life for them, and ultimately, help these children. That is congenital heart disease. We also have acquired heart disease, which these children come in contact with after they have been born. There are different types. The most common in our environment ranges from acute rheumatic fever leading to rheumatic heart disease and cardiomyopathies. If the opportunity allows me, I will elaborate more on those. Yeah. But I must mention that for rheumatic heart disease, acute rheumatic fever leading to rheumatic heart disease, it's actually preventable. Unfortunately, in the developed world, the incidence has reduced to almost zero, because with the advent of antibiotics, they've been able to curb it, especially penicillin. They've been able to curb it. But we're not yet there in this country. One of the predisposing factors for acute rheumatic fever and rheumatic heart disease is sore throat. So when we talk about prevention, when we talk about primary prophylaxis, it means we should not take sore throat. We should not take it lightly in children. It has to be well treated. If it's not well treated, is what leads to this acute rheumatic fever and then rheumatic heart disease. And rheumatic heart disease is one of the worst things that one can wish for anybody, because the patients have to live with it for a lifetime. When I say live with it for a lifetime, it means the patient has to be on medication for a lifetime, has to be in touch with the health system for a lifetime. But the good news is it is preventable. Please get me clear. I'm not saying every child that develops sore throat will have acute rheumatic fever or rheumatic heart disease. But studies have shown that 0.3 to 3% of these children go ahead to develop that. So what determines who develop it and who doesn't develop it? Genetic predisposition is one of it. Another factor are environmental factors, which has to do with poverty, overcrowding, poor nutrition, which ultimately causes a depression of immunity in these children and make them to be more predisposed. But I am pleading that sore throat be well handled in these children so that we can prevent acute rheumatic fever and ultimately rheumatic heart disease. And then for cardiomyopathies, which is also an acquired, most of the time an acquired heart disease, there's the congenital form of it, which I'll talk about later. The commonest is the dilated cardiomyopathy, which can complicate some illness, including.
Hello. Okay. All right. Seems that we've lost.
Infection, like so many of these ones.
Oh, okay.
Do you want me to pause?
Yeah, we lost you briefly for about 10 seconds there. Oh. Just, I think the internet. Okay. It's okay. We can hear you now.
Okay, I think anyway, I'll carry on. I think what happened was somebody was trying to call me using my phone that I'm using.
Okay.
Yeah, that was what happened.
Okay.
Right. Yeah. Okay. So we're talking about dilated cardiomyopathy. Yeah. It could be genetic.
Okay. All right. Again, I think we've lost you there.
And then it could follow infection. I'm trying. It has happened again.
Yes.
Let me just try and communicate with the person to stop calling. Or I will just, if you don't mind, let me change my internet supply. I mean,
yeah,
so that
it's all right.
Yes. Yes. I've changed to another internet source. So I think that should help things to be smoother now.
Okay.
All right. Okay, like I was saying, I was talking about dilated cardiomyopathy. It can follow many common illnesses like measles, even infection in some of these children. Some of them, when they even have what we call respiratory tract infection, some form of pneumonia, they can have that complication. Some of them, their heartbeat may just suddenly go high, and from that, dilated cardiomyopathy may be a complication of it. In fact, there is one that is not so common, which we have reported and we have published, which is called burns cardiomyopathy. Children that suffers burns because of the release of some toxins into the body, it may ultimately affect the heart, and then they may develop dilated cardiomyopathy. The good news about those is that they are treatable if they are picked on time. Quite a number of our patients with this, we've been able to manage them and they've gotten over it. It improves over time. But I must also mention that there's a congenital part of it, like the kinase anhydrase deficiency. That has to do with some enzymes, which ultimately has to be supplied. The dilated cardiomyopathy may follow congenital heart disease like cardiomyopathy also. It will follow another congenital heart disease that we call Al-Kappa, which is the way I can explain it is coronary artery should actually come from the aorta, but in Al-Kappa, coronary artery will be coming out from the pulmonary artery. Right. That is also correctable if it is picked on time. It's just a matter of removing the root of the coronary artery from the pulmonary artery and then implanting it into the aorta. And the child will get better and live a good life. That is a few words about dilated cardiomyopathy. There are other causes of dilated cardiomyopathy. Now, another form of cardiomyopathy, which most of the time is genetic and is dangerous, that I will want to mention, is hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy may be congenital or it may be acquired. In other words, they could be born with it or they could develop it over time. Most of the time, when they are born with it, yes, it's a dangerous thing because it's one of the causes of sudden death. So many of those people that we hear, oh, slept, didn't wake up, most of the time, they are heart related. And hypertrophic cardiomyopathy is a major culprit in that. Right. In fact, I must mention the case of one or two of my patients. I remember in 2007, a boy was brought to my facility, under my care. That is at Lagos State University Teaching Hospital. And why did they bring him? Because the two elder brothers, when they got to his age, they just slept and they didn't wake up. Wow. So they brought him. By the time they brought him, we did many tests, among which was echocardiography, which showed that he himself had developed this hypertrophic cardiomyopathy. The whole of the heart was filled with muscle, and there was hardly any place for blood to be. So what happens to that type of patient is they will keep fainting, they will develop arrhythmia, and then from there, they could die. Right. But if we pick that early also, we could help them, we could salvage them. There are some drugs that we can put them on, which could, there are many prominent Nigeria that have died from that. It's just that I won't want to mention names. In fact, there was a footballer on the field several years ago that just slumped on the field. The first time he went on his knee, he was encouraged by the coach to carry on. The second time, the third time, he collapsed, and that was the end of him. So even in people with sports, one of the things that leads to death, especially on the field, is this hypertrophic cardiomyopathy, which if they know, preventive measures can be taken. There's also a very prominent Nigerian that was playing basketball and then he collapsed and died. We also had, it was hypertrophic cardiomyopathy. And unfortunately for this person, a member of the family had died of that earlier. So hypertrophic cardiomyopathy tends to recur in families. And that is why it is very important that we pick it on time. Let me also mention the case of one of my patients that was picked around the age of 12 years. Somebody was just doing a small research among secondary school students and then listening to their hearts using the stethoscope. And the person heard a sound that was not normal. And because of that, sent this child to us and at the teaching hospital for us to do more tests. Wow. By the time we did the test, it was this hypertrophic cardiomyopathy. A 12-year-old, he didn't have any symptoms, he didn't have any problem. And you see, that's the danger of hypertrophic cardiomyopathy. Most of the time it is there, it doesn't announce itself, and they just come with, they just die suddenly. So this boy came in, was not having any symptom, and we made the diagnosis. We put on a particular medication that is to help to reduce the risk of having dangerous arrhythmia that can lead to death. And we persuaded the parent, because there was another male sibling, to do the same test for the boy and do for the father, because it tends to be autosomal, dominant. But up till tomorrow, the parents said no, that they were overwhelmed enough that they knew that one of the child had it. They were not ready to bear that in any other member of the family. They came for follow-up for about 2-3 years. Currently now they are lost to follow up. So we don't know what has become of that child. Wow. There's another case at hand, which a colleague of mine is even trying to publish now. Our adult cardiologists, where I practice, called our attention to the bone because 2 other elder siblings had died. And then after interviewing the mother said, "Oh, she has other children," and so they said to bring the other children and then send to us. We investigated. It's still this hypertrophic cardiomyopathy. Currently, we are following up the child. At least we've been doing that for about 2 years now. We usually have to call on them for them to meet up with the appointment, but currently it's fine. Wow. So for us to know that many of these this heart problem that you hear, somebody shouted from the sleep and died, most of the time they are heart related and they can be prevented. And it can happen, as it happens in adults, it does happen in children also. Wow. Now, I want to say more things about acute rheumatic fever and rheumatic heart disease. Okay. Like I said, it's one of the preventable ones, because if you pick it early, or if we treat sore throat very well, then that complication is not likely to arise. But I must mention that it is not all cases of sore throat that are bacterial in origin. More than 80% of cases, they are viral. But because this is not solely a medical gathering, I will not begin to mention, how do you differentiate a viral from, except the host wants me to go into that detail.
We can talk about
that. Do you want me to go into that detail?
We can do that later. Maybe you can come back to that after the general one.
Yeah. Okay. So, except that, quite a number of times, in less than 20% of cases, is bacteria. It's the bacterial one that are dangerous, that if it is not well treated, can lead to acute rheumatic fever and then rheumatic heart disease, which is like a life sentence. Okay. I don't know. I think now there are other forms of acquired heart disease. Okay. There's an entity that is called Kawasaki disease. Yeah. Okay. I want to call attention to Kawasaki disease because it has so many things in common with measles. And many, even practitioners, tend to confuse it with measles. Measles comes with rash. This also comes with rashes. Measles comes with fever. It also comes with fever. And then one of the differentiating factors is you just see these children, their mouth is unduly reddened. Although there's a rash in measles, which we call Koplik spot, it doesn't make the buccal mucosa to be red. But in Kawasaki disease, it makes it to be red, makes the palms to be red, and sometimes may be peeling. Even the soles of the feet may be red and sometimes may be peeling. Now, I'm calling attention to this because it is extremely dangerous. It was first described by Tomisaku Kawasaki in Japan. It is commoner in the Asian countries, but we do have it also among Nigerian children. In fact, if you Google my name again and put in Kawasaki disease, you see a report on it. Why is it dangerous? What happens is that reddened palm, the reddened buccal mucosa that is seen, is an evidence of inflammation. And that inflammation occurs in all the blood vessels all over the body, and including the blood vessels of the heart, which are the coronaries. And what does it do? It leads to ballooning or dilatation of the coronary arteries, which may eventually burst. And you and I know, if the coronary artery bursts, that is the blood vessel that supplies the heart, what will happen? The child will die. But that complication can be prevented if we make this diagnosis early. I've mentioned earlier that it comes with fever. So for any child that is having fever and the fever is on for more than 5 days, and with any of these other features that I mentioned, please, I am imploring the health practitioners to think highly of Kawasaki disease and either refer to appropriate specialists which can manage, or do the needful. Okay. Now, how do we prevent this complication of ballooning of the coronary arteries and bursting? If we pick it early, there is a certain medication that we can give. I must mention to you that the medication is expensive, but like where I come from, they tell you that money is not as expensive as life. It's expensive, it's not so readily available, but we still get it. We get it usually from a particular pharmacy in Ikeja, which I won't mention, and then we're able to use it for these children. If we use it early, it will prevent that complication. And I'm happy to say that for all the children that we have managed, close to about 10 of them, none of them have died. Wow. Maybe because some of them came later and we were able to use this, but we've been able to save them. Wow. In fact, let me mention the case of one of my patients that had to come and locate me when she came back from the US. She traveled to the United States of America and on arrival noticed fever in the infant. And when the fever was not going to subside after 48 hours, she was uncomfortable and then presented in one of the ER there. And they made the diagnosis of Kawasaki disease. And they had to give this expensive medication that I mentioned to you. They managed the child got well, and then by the time they gave her the bill, she just told them to sell her. That because even if they sell her, that they are not likely to get that much. But the good thing was that they want her to continue, to follow up with a pediatric cardiologist when she gets back home. And that was how she located me. I must tell you that in terms of expertise in this country, we're trying. Because I know I've seen a child with this Kawasaki disease, and because we were not able to get that medication on time, the parents, because they could afford it, offer to get a 6-hour flight and flew to London. Right. And by the time they got to London, right from the airport, the ambulance was there to pick the child. They confirmed the diagnosis, managed, and sent back to us. Wow. That complication is preventable, but it's important that we have it in view. So some of those children that we say die from measles, it may not actually be measles. It may actually be that they had Kawasaki disease, which is also an acquired heart disease. Some people think it's not in this environment, but I'm telling us that it's there. We have seen many of these children who have managed successfully. So I think, let me allow the host. It looks like I've given too much information.
No,
let me allow him.
Quite
guide.
Interesting, to be honest.
Thank you.
Very, very informative and interesting. there are just a few areas that I want us to just elaborate on, or maybe just at least to throw some more light on them. Example, we're talking about people might not understand what autosomal disease, autosomal dominant arrhythmia. We might just have to tell them a little bit about that. And then obviously the viral and the bacterial thing is important. We're going to come back to that. If you just throw light on the arrhythmia, the autosomal dominant, so that our viewers can just understand that. And then I will ask you one or two questions.
Thank you so much. When we talk about autosomal dominant, this is let me see. This is the way I can explain it using layman language. In other words, these babies they get it from the parents. They get this a trace of this particular illness from the parents. Now, in other words, genetic. It is genetic. In other words, they inherit it. I think people are more comfortable with that word inheritance. Yeah. They inherit it from the parent. But you will ask me that, but parents may not even know that they have it. Yes, there are many illnesses like that parents will have. They will not know that they have it, but they can give it to their children. And then what we now say, when they give it to their children, there's what we call autosomal dominant, there's what we call autosomal recessive. Autosomal recessive is to say that if father gives the child needs to get it also, possibly from the mother, to have two of it to be able to manifest. Or let me explain it in such a way that when we say autosomal recessive or autosomal dominant, in other words, the likelihood that the child will express it or manifest it is higher in autosomal dominance. And there's what we call variable expressivity also. In other words, how likely, even though they got it as being autosomal dominant, how likely are they able to manifest it? When we say 50%, it means 1 in 2 chances, of expressing it. And then when I talk about arrhythmia means abnormal heartbeat. Now, if I ask about normal heart rate, now they will tell us, the physician will tell us normal heart rate is between 60 to 72. And then we all know that normal heart rate, we know where it should start from. It should start from what we call the pacemaker, which is also called the SA node, which is located in the right atrium. This is the way I usually explain it to my students, that all the muscles, all the cells in the heart, they all have the tendency to start off a heartbeat. But the designated and the preferred place to start a heartbeat is the SA node. It's just like in a class. You have a class of 40. It means any of the class members, they have the potential to be class captain, isn't it? But usually we designate one person to be class captain, and possibly we appoint assistant. And that creative students in the class, everybody say, I am class captain. What do you think usually happens? There will be a lot of disorderliness or chaos. That's what happens in arrhythmia. Even though the SA node has been designated to control or to start the heartbeat, some other cells will just wake up one day because of abnormality and say, okay, now we too, we want to be starting heartbeat. But because they are not the normal one, they are abnormal. So they start it, and they start it in a haphazard manner, and they can actually throw up, dangerous tantrum, which can cause very serious havoc, including death.
Thank
you.
So
I hope that explanation of arrhythmia is
yes, I'm sure our viewers will grab that. Basically, so
then you wanted me to talk about referral.
Yeah. No, we're going to talk about the differences between viral and bacterial infection within the heart. Yes. Now, before we get there, how common is cardiac problem in children actually? How common is it?
Oh, okay. Cardiac problem in children is they are common. Right. The incidence is the same all over the world, like I've said. And I've tried to divide it. I said, okay, the congenital and the acquired. For the congenital one, the incidence is the same all over the world. In other hand, the incidence is for every 1,000 child that is given birth to, 5 to 10 of them are born with heart problem.
Okay.
So in the Nigerian, averagely in a year, about 7 million children are given birth to in a year. Yeah. So we're saying that up to minimum of 35,000 of these children that are born in a year may be born with congenital heart disease. Wow. It's as common as that. Wow. But of course, the level of awareness are very low, especially in the remote areas. So these children contribute highly to infant and neonatal mortality rates. Right. And that is one of the reasons why our rates, both neonatal and infant mortality rate for Nigeria is very high currently. In fact, when a child is born with any defect in any part of the body, the chances of dying is determined by, does this child has a congenital heart disease with all these other birth defect or not. The one that has a congenital heart disease is more likely to die. And most of the time, the reason why they die is because of the congenital heart disease. So that's for congenital heart disease. Now, for acquired heart diseases, like I've mentioned, are they common? Yes, they are common. For example, for acute rheumatic fever, rheumatic heart disease. In my center where I practice at the Lagos State University Teaching Hospital, averagely, we make diagnosis of 5 per year, at least since 2006. We make diagnosis, that is just for acute rheumatic fever, rheumatic heart disease, averagely of 5 per year. So for those periods, you ask me altogether how many children, for example, in a period of 1 year at Lagos State University Teaching Hospital, we see well over 300,000 children. And then when you put that figure together, so it is like 4.6 to 5 for every 100,000 children, attended to at the Lagos State University Teaching Hospital. Some might say, oh, this is low. Infection is commoner. Yes, it might be lower, but for those that have it, the incidence is 100% with them. And like I said, it's a life sentence. For those that have it, they stay on drug or medication for life if they don't die, in the recent time. Wow. So that is for. Then for cardiomyopathies, cardiomyopathies is more common. Like I've mentioned, so many different things causes it. And in our publication also, which are accessible online, you could put my name, you could Google many of these things. It shows for those also, we see close to at least about 10 for those in each year. And this means 10, all these 10 children have to be on medication, have to be on follow-up, and you hope things will get better. In fact, there's another type of cardiomyopathy which I didn't mention, the restrictive one.
Okay.
That is not so common, but we have seen cases of that. But that is not even amenable to anything. What is amenable to is cardiac transplantation, which we don't even have the facility in this environment, or even in the developed countries, many people are waiting. We've had at least about 8 in the last 10 years. We've had about 8 children without diagnosis in the last 10 years. Wow. What have we been able to do? We've just managed them symptomatically. All of them have died as I speak with you. Wow. So that is about that. I don't know if I've...
Yeah, thank you so much. That's quite exhaustive, to be honest. So in terms of, before we come to, the viral and the bacterial differentiating this topic, what would you advise the parents or the public, members of the public, to actually be looking out for in to make sure that we have this patient come up sooner? Because it sounds to me like the best approach is, one, we can identify these things. Two, when we identify, we need to start the right treatments, and that way we can reduce the number of deaths from these conditions. So for us to identify, like we know in our country now, it's better you empower the parents or the public to be able to pick this, and then they can come up earlier. So what are the things they need to be looking out for in children, especially after discharge from the hospital?
Thank you so much. This is the way I would want to approach it. I would want to talk about before the baby is born, when the baby is born, and then after the baby is born.
Okay.
So in that way, we may be a bit systematic. Yes. Now, before the baby is born, if there's any history of anybody having a heart problem in the family, the chances are higher. I won't want to, for maybe because of time, we talk about 3% risk, but even if any of the parents now has it, the risk goes higher. If any of the child of those parents have had it, the risk goes to about 10%. Right. So for anybody that history is in the family, then before the child is born, they should actually plan that pregnancy and be on the lookout. Now, also before the child is born, how else? There are certain medications that people should avoid. Non-steroidal and anti-inflammatory drugs have been associated with some hormones like estrogen has been associated with causing congenital disease. Alcohol has been associated. And then some drugs also, like antidepressant, like lithium, some anticonvulsants, they are more like, and then anticoagulant like warfarin. Those ones are likely to. Then illness in the mother also. For example, mothers that have SLE, their babies are more likely to come out with heart block. Mothers that have diabetes mellitus, their babies are likely to come out with certain illness. I'm not trying to scare people, but those are the things before the child is born. And then when the child is born, now, especially for the practitioners, many of those children that don't cry at birth, even though we know about perinatal asphyxia, children with major, when I say major, I mean complex congenital heart disease, they are less likely to cry at birth compared with children that don't have any heart problem. Right. So that's one. Then another thing is the color of the baby at birth. We all expect a baby to be pink. Once the color is in between, it's dusky, it's not pink, which we call cyanosis, it is a pointer to the fact that that baby may be having a heart problem. Another pointer may be fast breathing. The baby, remember the baby has now been born. We know that the respiratory rate of a newborn should be between 40 to 60. And persistently, it is high or higher than that 60. You should watch out for heart disease in that type of baby. Fast breathing, then even difficulty in breathing. When a baby is breathing, the chest muscles are not supposed to be going inside. If that happens, then it shows that something may be wrong either with the lungs or with the heart. And so it is better to check on time. Now, this baby has been born. We expect the child to breastfeed, isn't it? Yeah. Ideally, an infant, a baby is expected to latch on the breast and be able to empty the two breasts at each feed. A situation where a baby will just put the mouth and the breast for maybe 1 or 2 minutes, remove the mouth, it shows that that baby is getting tired because sucking is an active process. That may be a pointer to the baby having heart problem. Also, the baby may be feeding and then you see the baby covered with sweat all over, excessive sweating. That may be a pointer to the fact that the baby is having a heart problem. And now you give birth to a baby, the baby feeds, you expect the baby to grow. The baby is not growing the way the baby should grow. That may be a pointer to the fact that the baby has a problem. Or when the baby is giving birth to, you look at the baby, you just cannot picture it, but you see that this baby doesn't really look too normal. You can't see You can't say, oh, this baby looks like any member of the family. You know, you can say, use the word somehow, like the way some babies living with Down syndrome are. When you pick any of those things, when we have babies that have Down syndrome, when you put 10 of them down, about the books will tell you 5 in every 10 of them will have a heart problem. But from our own documentation at the teaching hospital, we even find that up to 8 in every 10 that will come across have a heart problem. Now, if a baby has problem in any other parts of the body, maybe that has to do with the hand, that has to do with the leg, or that has to do with the brain, you must always check the heart, because the likelihood of having a heart problem is also higher. What we call Bactil association. Now the child has been born. Okay, the child is now growing. Another thing is, if you see abnormal positioning in the child is sleeping, is folding the hand, folding the leg, which may be a feature of squatting. That may be a pointer to heart problem in that child. Or for parents, you will see that this child is always weak, complaining of this child that is now walking, is weaker compared with the peers, getting tired easily. That may be a pointer to the fact that the child has a heart problem. In fact, I'm sorry, let me cite this example. I have an undergraduate under my care now, 16-year-old, who has just been admitted. I won't mention the name of the university. And according to the parents, they've always thought that the boy is lazy. When they say the boy doesn't wake up on time. Then when they say do house chores, they believe that the child has been lazy. And then when the child entered the university, they asked the child, like any other person, to do medical screening. It was really because of the medical screening that the doctor picked a murmur and then sent for echocardiography. By the time we did echocardiography, that boy had tetralogy of Fallot.
Really?
The boy had lived with tetralogy of Fallot for 16 years.
Wow.
To make it worse, the mother is a trained nurse. And the boy had been diagnosed with digital clubbing all around. In fact, to make it worse, the father told me that, that he needed to confess that he had enrolled the boy in bicycling competition, the one that Lagos State government organized. Wow. And that when they started it, the boy just rode for a few meters and said he was tired and stopped. Nobody suspected that boy could be having that type of a serious heart problem. So just to let us know that the awareness is very poor. Now, when you look at the hand, the fingertips of this baby, and it seems broader than the rest part of the finger, which we call digital clubbing, that may be a pointer to the fact that there's a heart problem. I'm sorry, Dr. Oguremi, I appear to be talking too much.
No.
That's my field. I can go on and on, and continue to mention this. I must mention also that babies that are born via IVF, from our experience, the incidence of congenital heart disease is higher in them also. Wow. So, thank you.
Thank you so much. That's quite exhaustive. I mean, I can see. There's a lot there for you to talk about, but because of the time, we might have to have a second part of this one, maybe later on. But as it's looking now, where we have about a minute plus to actually round up this program. Is there maybe, do you want to still talk about this viral and back? Do you want to differentiate this for us, and then we can round up there?
Okay. Thank you. Yes. For viral sore throat, sore throat that are caused by viruses, and then compare with the ones that are caused by bacteria. Those caused by viruses, they tend to start gradually. In other words, you notice that the person may be sneezing, maybe tearing, maybe, have other features, of infection, or sometimes they may have small cough and then they have a sore throat. That's more likely to be viral. But unlike the bacterial one, it tends to start suddenly. And then the fever in the viral one, the fever tends to be less than 38 degrees or around 38 degrees. The fever for the bacterial one tends to be higher, about 39 degrees and above. And that is why some of these children with sore throat tend to convulse. So it could be responsible for febrile convulsion in them. Now, another thing is for the health practitioner, when you look at it, when you check the throat of the baby, for the viral one, you could just see hyperemia. But for the bacterial one, you could see exudate, around it. And when you look generally at the look of that child, for those that are bacterial, they tend to be more toxic looking compared with the viral one. I'm sorry, one of the pointers to congenital heart disease or acquired heart disease in some of these children is cough. If a child keep having cough frequently, in fact, we tend to say that if we admit a child for pneumonia the first time, by the time we're admitting the second time, we must rule out a heart problem in the child. Thank you so much.
Thank you so much for that. Unfortunately, we couldn't go on Facebook today because we had some technical itch, so we do not have many people watching this live. We're going to push this on Facebook, and to ask Prof, and we them in this session. Please, you can comment below. We're going to pick the comments and we'll get across to you. We get Prof to also possibly come online to answer your questions. Really sorry about it. We couldn't help it because it's just one of those things in our country again. Maybe not our country this time around, maybe it's Facebook. For one way or the other, we couldn't go there live. We hope you still find this very interesting and you find it very informative. And if you have other questions, if you have any concerns in anything that we said, again, just drop the information here. It is clear to us now from what we've heard from Prof. Heart problem in children is something that we need to take seriously. It could be that thing that you pick that might save this child's life. So don't let us ignore it. If there are issues, you've heard all the signs and symptoms, things that you need to look out for. If you find any of those things, please just contact your own doctor, and then with a view of you getting somebody who can actually help this child so that we don't needlessly lose our kids for things that we can actually act on promptly to save their life. You're very much welcome for this program. Prof, we really thank you for your time. We know you're busy. I always say this, and we're not taking that for granted at all. Thank you so much for coming today. And do you have a last word for our audience, or we are good to go now? Hello?
Hello?
Yeah, do you have a last word for our viewers?
Yes, for our viewers.
Yes.
Heart problem is also in children like in adults. But please, the good word is that the good thing about it is these children can be helped. The heart problem can be managed if we pick them on time. So parents, please bring them on time. Thank you.
Thank you so much. And to the viewers, enjoy the rest of your weekend, and bye-bye. Right.
Thank you.
Okay.
Bye.